I mean, let's be honest, in a regular eye exam, putting patients behind that phoropter and flipping the dial, which is better, one or two, really it doesn't work for low vision patients. So I do a refraction by hand. Again, I'm using special charts so patients can really see the difference in the prescriptions changes that I'm showing them. This is an example of a patient who was referred to me by Dr. Tolentino just a few weeks ago. I'll call him Mr. D. He's a 91-year-old man with macular degeneration. He had 2200 vision in each eye. He also had cataracts. He came in saying he couldn't read, having trouble reading, and the reading was so important to him. He hadn't read in several months, even longer. He had struggled with it for years. So anyway, he'd see Dr. Tolentino here, and he'd go back north and see his retina specialist in Michigan, back and forth. Well, he really hadn't had his eyeglasses checked, so that's the first thing I do. I checked his prescription and refracted his right eye from 2200 to 2040. His left eye from 2200 to 2070. You know, very significant change. Probably was because those cataracts were forming. It's not very common we see a 91-year-old with cataracts, but he did have them. And as cataracts form, it can cause the prescription to change. But this was never really thoroughly tested and thoroughly addressed. But the good news for Mr. D is that I could give him a new pair of glasses. He saw so much better right away. Talked to him about lighting, and with that, he was set. He went off with his prescription, his special lamp, and he was doing terrific. I talked to him 2 weeks ago. His wife got on the phone. She said, oh, he loves his glasses. He has not stopped reading since he got them, and he is so grateful. So a prescription did this for him. A good refraction did this for him. He didn't need to go on to the training and the low vision devices and the occupational therapist and the home health. He didn't need that. He needed a good prescription. So I really feel strongly that a low vision exam should be part of the rehabilitation care, because so many of these patients are not being treated properly if they're sent directly to more advanced low vision without that proper assessment. Okay, I'll get off that soapbox and talk about lighting, because this is by far the most common thing I recommend to patients is good lighting, because macular degeneration makes the vision faded. And so if we increase illumination, it helps those nerve cells that are a little weak, a little sleepy, they kind of wake up. If we can put a lot of light on things, they kind of act better, and patients actually can read significantly better just with the right lamp. I like this lamp by OttLight. It's called the Better Vision Series. You can look it up online, ottlight.com, OTTLIT.com. And it really is made for patients with macular degeneration. It's a much more intense beam. It comes in a floor model, a desk model. The important thing is you can bring the light down really close on top of the material. I also like high-intensity flashlights. And again, this is by far one of the most common things I recommend, especially when patients have a moderate impairment. Some patients are not that lucky. Some patients have more advanced disease, and what this slide shows on the left is a large area of degeneration. And obviously that central vision, so degenerated, is going to have significant vision loss right in the center. So that's what we call a central scotoma, or a blind spot or a bad spot right in the center. And what it creates is a bad spot in the patient's vision, right where you want to see, right when you're looking at someone's face, the bad spot's right there. It might not look like a black spot, so sometimes I hesitate to call it a blind spot. And actually, one study showed that 85% of patients who have central scotomas don't even realize they have one. They don't even realize it's there. They're just unaware. The brain kind of fills it in, just looks kind of gray and shaded. So oftentimes we need to teach patients where this blind spot is and how to look around it, and how to look around it in a consistent way so they develop eye patterns that they can use the peripheral vision. So that's called eccentric view training. So part of my program includes eccentric view training, sometimes before I even prescribe a magnification device, because I think the magnification device will work better once I get them looking around that blind spot better. This is where an occupational therapist comes into play. This is where I use my occupational therapist in the office. I'm very lucky I have an occupational therapist who has extensive experience in vision rehabilitation. Most occupational therapists are experienced in rehabilitation in general. They might work with stroke patients, they might work with upper extremity orthopedics, like carpal tunnel surgery, rehab, and things like that. But some OTs actually do additional training in low vision. My OT, her name is Yolanda Kate. Yolanda actually is one of the instructors at University of Birmingham in Alabama who trains occupational therapists as part of their program in vision rehabilitation. So I'm lucky to have her on staff. She does eccentric view training with my patients. She teaches them how to use the low vision devices. She also goes and teaches them some different ways of doing things, or what we call adaptive strategies, some new techniques, how to compensate for the vision loss. And also, she does home visits. I think it's very important for her to go in the patient's home, look at the patient's environment, look at what modifications can be made to that environment, and then make some adaptations and train patients how to function with those adaptations. And then finally, she looks at fall prevention in the home and functional mobility. Just around the patient's home, she can identify obstacles and identify some risk areas. So having her go through some of the non-optical devices, some of the signature guides, large print checks, things, real nice little tools besides the low vision device equipment, some other things that she can integrate into the patient's home. So now a little bit about low vision devices. They have to be pretty much tailored to the patient's needs. And I mean to their level of vision, to their blind spots. So signing on a low vision device, I take into account the patient's goals. I want to know about the patient's specific activities they want to do, and then really design a device that's right for that activity. And considering the vision and the blind spots and the contrast and all those things that I assessed in my exam. And I also need to consider the patient's motivation, because motivation plays a very big part in how successful patients are with rehabilitation. So I want to take that into account. Some devices are more difficult to learn how to use, and I know that patient isn't going to have the patience to learn how to use it. So I have to be very practical. And also, speaking of being practical, it's the cost. These things have to come out of patients' pockets, so I have to be sensitive to where the patients, what their budget will allow and what they can afford. Most of the time, patients come in and they say, I just need stronger glasses. Please, Dr. Braudway, just a little bit stronger. And I tell them, okay, let's try it. I'll put a pair of strong glasses on them. I decide what power based on the low vision exam that I've done. Maybe a power of 10. Most of our reading glasses, for normal vision are around maybe a 3 diopter. So a power of 10 is really pretty strong. But what they soon realize is a power of 10 reading glasses, they have to hold things extremely close. A power of 10 glasses is focused at about 4.5 inches. So as soon as they put those glasses on, they have to hold things up at 4.5 inches. They start complaining. And, they have to be taught that it takes practice learning how to use strong reading glasses. Now, if they need an even stronger, a power of 20, they're going to have to hold things at about 2 inches. So imagine reading a newspaper 2 inches from your eyes. Okay, it takes a lot of practice, but some patients do it. Here's a patient I fit in what's called a univision microscopic bifocal. This gentleman saw me in 1997. Kind of tells how long I've been around. But he does have a power of 16 in his bifocal. Most of your bifocals are maybe a power of 3. His bifocal is a special one that's designed with high power magnification of 16. So he has 2200 vision and has been doing well with this 16 Doppler bifocal for a while. He wears it on a strap around his neck, and he puts them on when he needs them. He sees his cell phone, he sees his watch, he reads the newspaper this way. I mean, he's really adapted well to it. But when he came in the other day, he said to me, Dr. Braudway, I owe you such a debt of gratitude for my fish-eye glasses. He calls them fish-eye because they do look kind of bug-eyed, real thick there at the bottom. But he said, I just love them. I can't be without them. And my strap broke. It fell off my neck, and I can't find them. And I'm about to go nuts. So he just came in, for another pair. So these are patients that really can adapt, but the right device has to be selected for the right patient. Here's an example of telescopic glasses. These glasses are used mostly for distance, and I see some people in the audience today using their binoculars. If any of you have looked through a binocular or a monocular, you can appreciate the benefit of magnification for distance. Well, sometimes we can put that magnification into glasses. So we consider telescopic glasses for distance, but also we can modify them to use up close as well. So that's a consideration. Another low vision device that most of us think of, and is certainly the bread and butter of low vision devices, is magnifiers. And I'm talking about the magnifiers you hold in the hand or the magnifiers you stand on the paper. So when we have those magnifiers available to patients off the shelf, in a Walgreens or Staples, over the counter, they're usually very low power. Maybe a 6 is the strongest you can find. Well, in a low vision clinic, usually the magnifiers go much higher than that. I have magnifiers up to a power of 56. So, much stronger magnifiers with varying designs, and usually they have a light source built in that's very good. These are designed for people with vision loss. Video magnifiers. We use video cameras to magnify. You saw an example out in the exhibits today. Freedom Scientific has an amazing video magnifier they call the Topaz. The Topaz is their desktop CCTV, that's the other word for it, or enhanced vision system makes the Merlin. Video magnifiers are very powerful tools, but patients still need training to learn how to use them. The cost is one of the factors, between $2,000 and $3,000 usually. So these are some of the things we have to consider. We have handheld video magnifiers now. Here the technology is really evolving into other ways to use video magnification. The Pebble is one by Enhanced Vision Systems, and that's one of the drawings out of the registration desk today. Also the Ruby is by Freedom Scientific, which is a really well-designed handheld video magnifier. Smaller field of view, takes a little practice to learn how to use, but it's another option. They range between $400 and $800. And then computer adaptations. As I said, this is really important, and I think that patients need to know that there's even in their computer, in their operating systems, ways to magnify the print. They can also get a Zoom mouse from Staples, real easy way to get magnification. Or large print software. This is for more patients who need more or higher level of magnification, such as Zoom Text or Magic. Those are just a couple examples, and these are things that we go over, and even my occupational therapist or sometimes a technology consultant from the lighthouses will help patients decide what computer adaptations are best. And large print keyboards are available, real simple thing you can get even at Staples. So that gives you a little synopsis. Now I would like to